So, Bismillah ar-Rahman ar-Rahim. As I mentioned in the last lecture, I told you that I will give you a bit of a hint and tricks about the plan for a cancer larynx patient. I don't know if this is still coming in the exam, but this was a very common question in the exam. They give you a cut section, single cut, whether it's a CT or whether it's a drawing, and he tell you how would you get a nice plan? And sometimes he put the wedges here, and sometimes he doesn't put the wedges. The idea of using a wedge is here clearly because of the slope of the neck, which the wedges will act as a compensator to compensate the difference between the SSD here and the SSD here. Usually the exam question will come and say, this is a very nice plan with 95% dose coverage, but we found 120 hotspot at this corner, and then he will ask you, so how would you improve it? And then the quick answer, because you are very stressed in the exam, you would say, oh, if I want to reduce the dose here, let's make this angle, and you put it in, because this is in your mind. I know what this is what usually happens. Let's make this angle thicker. So, and you say, I will increase the wedge angle. So instead of like a 30-degree wedge angle, I will use 45-degree wedge angle. And if you said that and this answer, you will definitely fail, because this means that you didn't know anything about the physics. And majority of the time, and whenever this happens, I can see, and I'm 100% sure that it's just a kind of stressful situation of the exam, and you just answer by default. So please, if this comes to your mind that I have to increase the wedge angle so that I get rid of a hot spot here, this is a wrong answer. Hold it, hold it, hold it, again, hold it, and think carefully. This is not the wedge angle. Go back to your physics. The wedge angle is the angle created by the tangent of the 50% isodose line, not this one, by the way, it's down there. It's 50% isodose line, a tangent of the 50% isodose line with a vertical line going to the axis. This is the wedge angle. So it's the angle between the tangent of the 50% isodose line and the central axis. If you increase the wedge angle, what would you do? If you increase the wedge angle, you will make a large difference between the point here and those under this end here. So if we increase it from like 35 to 45, what happens is that instead of being the 50% is here, this will come down and this point will go up. Something like, so we are increasing the wedge angle, yes, something like that. So this point will go down, okay. This will go down, so the isodose line will shift toward the thin end of the wedge. Is the wedge angle, we're talking about a differential dose between this end and this end. If you increase the wedge angle, you will increase the hot spots under the thin edge of the wedge, because what's happening is all this will be hotter, yes? But if you reduce the wedge angle, so instead of moving it to this side, you're moving it to this side, what's going on is you are reducing the difference between the dose in here and the dose in there, which means that this will move up, so you are reducing the hot spot under the thin edge of the wedge. So what are we doing here is, if he give you a hot spot in there and said this is 120%, reduce the wedge angle. Reduce the wedge angle. This is very important. What would you do when you reduce the wedge angle? You are pushing the hot spot to the front. So the hot spot will move from here to here. And then you can change the wedge to an extent that will not give you a bad quality plan. But sometimes what I usually do, when my colleagues, the dosimetrists, they give, or the physicists, they give me a very nice plan, an ideal plan, let's say with a wedge of like 35 or 45. What I usually sometimes do is I tell them, please make the plan worse. Why would I make the plan worse? So I use what we call it under-wedging. This is not haddadiyat, by the way. This is something physics, and a lot of people, I'm sure that a lot of people are doing it. And you maybe read it, you can read it in the book, but you may not understand what does it mean. So I usually take the opportunity and describe it, because we use it quite a lot back home actually. And what happens is, if the plan is ideal, let's forget about the red lines. Let's forget about it. Okay, so let's move. I don't know if I can move the red lines. So forget about the red lines. Okay, let's look at this plan. It's an ideal plan. You can see here 95% coverage, everything is fine, 100%, and maybe the maximum dose is maybe 105, and everything is ideal. So what I do is I ask my colleagues is I tell them, so this is an ideal plan with a wedge of like 45 or 40. I would tell them, please try for me a wedge of 30. So they will say, yeah, but if you reduce the wedge, what happens is the dose will be concave here and you'll not get a nice dose distribution. I tell them, yes, this is what I want. This is what I want. What does it mean? This is what you want. Yes, exactly. I want the 95% curve to curve like that. So the isodose line will come something, I'm exaggerating here, but you will see that, please try it, and this is not, I mean, it's physics. So you try it yourself. Ask them to reduce the wedge angle to make it a bad plan, okay? So what happens is the posterior isodose lines will move anteriorly. So what I'm doing is I'm pushing the high dose region, the 95%, away from the posterior pharyngeal wall. Do you want that? Yes, definitely. Why should I push a lot of those in the anterior pharyngeal wall in a early glottic cancer, T1, and we don't have to, yeah? And also there is a second point. The second point is we are moving the hotspot anteriorly. Anteriorly means anterior tumor, anterior commissure means anterior glottic tumor. So you have a hotter dose on the tumor itself, as if you are giving a higher dose per fraction. So instead of the patient will take like a 2 gray, he will take 2.1, he will take 2.2, depends on how much dose you are pushing anteriorly. As if with a 2D technique, I'm doing a simultaneous integrated boost. I'm giving part of the tumor or part of the larynx 2.2 gray per fraction, while I'm giving the posterior pharyngeal wall 90% isodose line or 85%, whatever. What depends on the separation, depends on a lot of stuff. By the way, it's not like a straightforward plan, but it's nice to discuss it with your colleagues and see how it works. And then, so I'm reducing the dose in the posterior pharyngeal wall, which is an ideal, and I'm pushing more dose anteriorly, which also, this is what you want. So in a very simple way, using a 2T technique, you can play with your dose, push dose anterior in the tumor as if it is simultaneous integrated boost. I just want to stress on this fact, please, don't rush and say, I will increase the angle of the wedge. It's a very common and stupid mistake with the stress of the exam. It usually happen like that. I don't know if it's still coming in the FRCR exam or not. Maybe it's not nowadays, because most of the team would, like, say, I would treat IMRT, I would treat with other stuff. The second point I want to stress in, if you are doing a 2D technique, please take care of something. If you're doing two lateral fields and your patient shoulder is coming inside the lateral field, so patient has like a stuck neck, very short neck, and the larynx is stuck down, so that when you go to the lateral field, you want to put the lateral field, you cannot, and you find yourself in a position of hitting his shoulder. Um, Once upon a time, I was saying that I will hit the shoulder, and one of my colleagues was saying, "So what's wrong with that?" I mean, clearly, why should you irradiate the shoulder? I mean, you don't have to irradiate your shoulder, yeah? So please don't irradiate your shoulder. I mean, first, you will not get a nice dose, and second, why would you irradiate the shoulder? I mean, you don't have to do that, yeah? So what you can simply do is to just do it, what they call it, inferior angulation. They call it inferior angulation because of the direction of the beam, as if the beam is directed upward. So this is one method that you can move the gantry up, and this will direct the beam down, and then you are getting away, you're staying away from the shoulder of the patient. But this, please, this is very important, and I usually find that a common mistake happening there. If you change the angle up, please, like that, sorry, something wrong. I want to rotate. How can I rotate? From here. So if you are doing something like that, okay, so look what happened. What happens is, it, like, uh, it's not my slides, by the way. It's really beautiful slides. Thank you, or whoever prepared it. So if you are dead lateral, that's fine. I want you to just notice something will happen. So now you opened your field laterally, and you know that this is anterior border, this is a posterior border. When you move the gantry down, you have to be very careful because you need to have a wide direction field. What does it mean? So let's exaggerate it and go down. So when you go down more, what happens is, look at this, the corners of your target, which suppose this is like the larynx, the corner of your target is getting closer to the beam. So you need to open this up. So again, so when we were here, it was nothing wrong. You can see it clearly. I don't know why I'm using the yellow color. Let's change it to a different color. I don't know why it's yellow. Can we change it? Sorry, I will not waste your time more than that. Don't know, can we? No, shape maybe. Yeah, so this is much better now. So if you are dead lateral like that, there is a nice, so it's not ideal. So if you are dead lateral like that, you can see there is a nice space between the target and your volume. If you change the gantry, yeah, you're getting closer to your target. So be a bit generous. So if I'm taking like 4 by 4 centimeter, you may need 4.5. You may need 5 centimeters. So be careful when you do that to have a look again on the simulator or on the planning system to make sure that you are covering, especially in the upper direction and the lower direction. In a very similar way in the hypopharyngeal cancer patients. I think we are doing it. Yeah, it's here. So if you do that, please be generous and open your field, especially up and down. This is the same as what we call the inferior angulation. If there is a shoulder, when you treat a hypopharynx or lower neck, if you remember when we talked about the couch movement to open the shoulder, we move the head towards, we move the couch towards the head of the gantry to open the shoulder. When you do this movement when you move the couch toward the head, you also have to open the field up and down. Otherwise, you will compromise your target. So you have to be very careful in doing that. I'm sorry for the phone. So you have to be very careful with that. And this is one of the points that I wanted to stress at. And I want you to be generous. If you remember, we talked about the three field technique, and also we talked about the 2D, about unequal weight. You can increase the weight from one side and reduce it from the opposite side. So I'm not surprised if you decided to go for T1 glottis, very localized. You don't have to worry about it much because it has been done for a very long time. I mean, it's not new, but be careful if the information about your tumor is missing, and if you want to to be a bit generous. Just for those who are taking the exams, there is some clinical trials that you have to be aware of in cancer larynx. We mentioned two, Yamazaki Moon, and for those who are Arabic speaking, you can remember it by Yamantazaki Yamun. Forget about this. I'm sorry, it's not science. I have to respect science. So Yamazaki and Moon. Yamazaki is the Japanese group. You can just say Japanese group and the Korean, South Korean group. They proved, or they give us an evidence that hypofractionation is much more effective in T1, T2 glottic cancer more than the normal fractionation of 2 gray per fraction. You can use 2.25 gray per fraction. I would like you to have an idea about the Hanka group, the HANCA 7 and 6, but this you can use it for the locally advanced disease. You don't have to use it for early stage because the majority of patients in the HANCA were in the advanced stage disease, so you don't have to worry about it much in early stage disease. In hyperfractionation, I would recommend the RTOG 9512, but you don't have to, because I don't think that there is a lot of centers working with hypofractionation, and I'm not really, I don't see that it's coming in the exam as a common question. I hope you will not face that. But if you want to have a quick look at the 9512, I think this is a good clinical trial. You also have to be fully aware of the trials for laryngeal preservation. Maybe I can do it quickly, and then maybe I can do it again with the hypopharynx. But you remember with me the VTA, veterans affair, and the URTC. One was the in the larynx patients, and one was the hypopharynx patient. Interestingly, the URTC trial, they used the hypopharynx and area epiglottic fold, because as I just mentioned, this, so you don't know exactly that an area epiglottic fold belongs to the hypopharynx, or they consider it as a pure larynx. So if it's a laryngeal side, yes, you can say it's a supraglottic region larynx, but if it's hypopharyngeal side, or if it's both, which is sometimes the case, you don't know exactly. So one of the smart ideas, I think, of the URTC trial, and this both the URTC trial is to include the area epiglottic fold as part of the hypopharynx, and take it from, for the group of patients, use the neoadjuvant chemotherapy followed by radiotherapy. It's very important to stress on the fact whether the veterans affair or whether the EORTC trial, if the patient is not responding for the neoadjuvant, please go for surgery. And this is very important point, because some of the I don't know, but I mean, it makes no sense if the patient is not responding at all and you are insisting to give him 3 sessions of chemo. I mean, it makes no sense. You have to assess your patient early, and the quicker the response, the better the outcome. So if the patient is responding, like have a partial response after the first session, second response, a complete response after the second, this is a great patient for conservation. But if he's not responding, don't try, don't waste your time. Go for surgery and give postoperative radiotherapy. And this is very important, I think, because we have to be more cautious nowadays about laryngeal preservation, guys. I mean, it seems that we are. I mean, the choice of the patients. I don't believe that we are doing the right thing by choosing the patient appropriately. It should be a combined approach. ENT team, speech therapist, dietitian. The whole team should take the decision together. Because if you looked at the SEER data, the most recent SEER data, there's a big question mark saying that the survival of cancer larynx patients are going down. So if you compare the survival for cancer larynx patients in the last like 10, 15 years compared to before that, so before like 2007 below, or before 2007 and after, it seemed that the survival for our cancer larynx patients are going down, which is really sad story, because we shouldn't do that. You have to be very careful. Yes, we can conserve, but who should conserve, and which patient do you choose for conservation? I don't want to go through that again, but just for the quick clinical trial that you have to focus at. So we talked about the early stage. For the advanced stage, veterans affair. Veterans affair is very nice numbers, by the way. If you are one of those who are happy to those who like to remember the number, it's a number of 3 and 6. So 332, the number of patients, the median follow-up duration was something like 30 months, and the disease-free survival was around 60 something percent. So it's a really nice if you choose also figures that you can remember along all through your life. You will never forget it. The EORTC trial is very nice because they updated the results. So the veterans affair, the median survival was very short. That's why it's one of the drawbacks of this trial that they didn't update it. But when you talk about the EORTC trial, I think they updated up to 12 years survival, median survival. So it's a good trial, and it's nice. You have also to be aware of the tax 323, tax 324, which is, I mean, if you understand how we manage things or how we are thinking, Then you understand what is the sequence of the clinical trial. So first we give chemotherapy, and we compared chemotherapy followed by radiotherapy, and then radiotherapy against the surgery and post-operative radiotherapy. This was the early trials. But when it came to that, the concurrent chemo-rad is a standard of care, so we have to modify things. So with the TAC 323, if I remember correctly, we tried to see if the TPF is better than the PF in the neoadjuvant setting, which is fine. And we proved that the TPF is more toxic, but it can preserve more larynx. And be careful, please, with the docetaxel. This is radical treatment. Don't forget to give you growth factor antibiotic and follow your patient properly with TPF. After we found out that adding the taxotere is better, let's see if concurrent chemo-rad will add to the neoadjuvant chemotherapy. And then they gave the TPF followed by concurrent. But the problem with the concurrent we give the carboplatin. We know that cisplatin seems to be more effective, and whether or not we have to repeat it and do the carboplatin or the cisplatinum with the TPF, but because of the toxicity of the cisplatinum, we didn't want to give it in the adjuvant or the concurrent setting. In the concurrent setting. So TAX 323, TAX 324. If you are like a superstar, you can also know the trial used. I think it was. What was in the first author? I can't remember. It was like comparing concurrent cisplatinum versus cetuximab radiotherapy versus cisplatinum radiotherapy. It was a phase 2 trial. I wouldn't recommend it. It was neoadjuvant followed by concurrent cetuximab radiotherapy or cisplatinum radiotherapy. I don't like this trial because although the survival was equal, but if you looked carefully, you'll see that more salvage surgeries were done in the cetuximab arm, which means that the local recurrence was high and that salvage surgery were able to neutralize the effect of the recurrence happened in the cetuximab arm. So I would be a bit reluctant to consider the cetuximab for all patients. One of the nice trials as well that I was really very sad when it first appeared, the 9111. I don't know if they call it 9111 or 9. Sometimes they write it like that. It's 9111, and this trial compared the neoadjuvant as a one arm. They also, there was multiple arm, but what I want you to take home from this trial, the 9111, that this trial confirmed that the concurrent cisplatinum plus radiotherapy is the standard of care versus the neoadjuvant. But the strange thing happened after the long-term follow-up, and it was really interesting that it seems that the neoadjuvant didn't do as bad as the concurrent. A lot of patients died in the concurrent arm, and we didn't know what happened. And it seems that because of the toxicity of the concurrent chemo-rad, they may end up by patient having a lot of aspiration, and they may die from other causes than laryngeal cancer or recurrence. So I would recommend that you have a look at the 9111. So these are, I think, hope I'm covering what I covered like that, the most important landmark trials. And if I remember something, or if you remember something, please let me know. I'm sorry that I took so long in cancer larynx. I didn't know that it would be that long, but I hope it will be useful for you. Again, if you like this lecture, you don't have to subscribe. Please pray for me. Please pray for me and for my father, who just passed away a few weeks ago. Okay, thank you.